Point of care testing in Helicobacter pylori. H. pylori is a gastric gram-negative spiral-shaped microaerophilic bacterium strongly associated with gastric and extragastric diseases. These diseases include peptic duodenal and gastric ulcers, chronic atrophic gastritis, mucosa-associated lymphoid tissue lymphoma, or MALT, as well as liver and gastric cancers. Current estimates indicate that around two-thirds of the world population is currently infected with H. pylori, and studies indicate that rates are far higher in the evolving countries. This is most likely due to the lack of industrialization, socioeconomic status, and hygiene standards. There is still no gold standard for the diagnosis of H. pylori due to the variability in the samples used for diagnosis, as well as the variability in the specificity and accuracy of the tests used. There are several testing strategies currently in use, which can be broadly defined as invasive or non-invasive. Rapid urease test, histology, PCR, NGS culture, and molecular testing are considered to be the invasive methods. And non-invasive tests include urea breath tests, stool antigen testing, and serology, and point-of-care methods. Current near-patient testing methods used for H. pylori diagnosis. Several rapid detection kits have been developed for the quick diagnosis at the patient bedside. Kits designed for H. pylori can use a variety of sample types, including stool, blood, and saliva. Stool antigen RTGs. Most of these RDTs use rapid lateral flow immunoassay that uses anti-H. pylori antibodies as the capture and detector antibodies. Monoclonal types are reliable with high sensitivity and specificity and are useful in detection of current infection in patients as well as post-eradication follow-up, even in patients with severe gastric atrophy or intestinal metaplasia. Serology RDTs typically use specific IgG or IgA. Like other RDTs, these are simple, quick, and do not need medical science expertise and can be easily run in remote care facilities. These are recommended in patients with GI bleeding, malt lymphoma, atrophic gastritis, or gastric cancer who may have lower bacterial loads. Saliva RDTs. Since the early 2000s, saliva has become an increasingly investigated area as the routes of transmission for H. pylori remain clear, but the current main theories for transmission include the oral to oral and oral gastric routes, which are deemed to be very important for H. pylori, and the mouth could be an extra gastric reservoir for H. pylori. Serial breath tests are a non-invasive and non-hazard form of diagnosis. The test utilizes the large amount of urease produced by H. pylori. Urea is labeled with carbon isotopes, either carbon 13 or carbon 14, to label the urea. The urea then hydrolyzes the orally given urea into ammonia and labeled CO2, which is then excreted by the lungs and can be measured by analysis of the patient's breath. Sensitivities and specificities have been shown in studies to be 90 to 96% and 88 to 98% respectively as a secondary test. And here's an example of a point of care C-urea breath test system. The breath ID HP, which utilizes continued validation of the patient breath samples through a nasal cannula and takes around 30 minutes. Advantages. There are multiple advantages to these non-invasive testing methods. The invasive procedures require intense clinical overview and specialist technology and expertise. Many of the testing strategies used for H. pylori diagnosis are invasive and present a severe risk to the patient. Biopsies require patients to be anesthetized and undergoing invasive surgery or endoscopy. The kits are designed to be cheap and stable, which means they are a viable option for disadvantaged areas and countries, as well as being easily incorporated into GP practice. C-urea breath test, while as a near patient means of diagnosis, does require a trained professional to ensure the procedure is adhered to and must be monitored. While most use C13 now, C14 can be used, which demonstrates an increased risk to the patient because it is radioactive and cannot be used in women or children. Near patient testing are designed to be quick, with most RDTs readable within 5 minutes and newer C-urea breath tests needing 30 minutes. Lab serology and biopsies can take days or weeks to return results due to the nature of clinical labs and the special expertise needed for the reading of results. Biopsies in particular can demonstrate variable results. If the wrong area is biopsied, there can be false negatives returned as it may not sample an area with H. pylori infection. Near patient testing methods are designed to be clear and simple to read and can be easily trained to non-experienced staff or clinically experienced staff as well. Disadvantages. A wider look at the variety of published data demonstrates varied results from high sensitivity and specificity to termed inconsistent results. Perial demonstrated that in post-treatment patients, 8% of patient testing using stool RDTs were discrepant or inaccurate due to the variability of how the treatment affected patients. Another disadvantage when it comes to stool RDTs is that patients can be quite squeamish about using them simply due to the nature of the test. As with all testing conducted outside a laboratory setting, the quality systems may not be as well integrated to ensure tests are carried out in an appropriate manner. With QC may not be run as regularly as it should be. New lot numbers may not be QC. New lot numbers may not be recorded, and patient results may not be entered into systems as accurate as they should be, and there may not be any secondary checks or overview. Serology results can be affected by a diverse group of factors. False negatives can arise in early infections where the immune system has not yet fully mounted a response. And in developing countries, there have been documented cases of co-bacterial infections, which are rare in the developed world, which can affect the specificity of tests and may not be anticipated by companies producing the RDTs in the developed world. Lab serology tests need very little patient time with a simple blood draw when compared to tests such as serial breath tests, which requires patients to remain outpatient setting for at least 30 minutes, especially now in the current pandemic with outpatient settings are rare simply due to the risk of infection from coronavirus. These sort of testing methods present increased risk to the patient and may not be actually feasible. New stool antigen testing kits have comparable accuracy to the urea breath tests. However, there is one specific disadvantage. Antigen excretion can vary over time and degrade as a stool passes through the intestine, and age of the patient can also affect the antigen expression in stool samples. Since discovery H. pylori in 1983, a wide number of detection methods have been developed, but as yet there is no gold standard established due to the variability and sensitivity and specificity of these tests, which means new tests being developed have no gold standard which be compared to, so this issue continues to propagate. Novel point of care testing methods for H. pylori. Obtaining a quick and accurate diagnosis of H. pylori is one of the major challenges to date. Newer technologies can provide the potential to provide accurate results within a couple of minutes to a few hours. Microfluidics have been increasingly recognized as a solution for near patient testing in global health crises. For H. pylori, integration of immunoassays onto microfluidics have led to lab-on-a-chip systems. Aptamers have also been developed for a quick means of detecting H. pylori with a visual reading, which would be easy to use in remote areas with limited resources and limited training capabilities. Microfluidics. In these system, H. pylori antigens are fixed to the wall of the microchannel. Microfluidic systems can vary depending on the approach taken to take the target. Chow et al. Have developed one microfluidics-based detection system for H. pylori, as you can see here. This system utilizes micropumps, microvalves, with the integration of cybergreen for the PCR stages, resulting in a fluorescence intensity measured directly in the microfluidic system. This test is not only used for H. pylori detection, but also for the antibiotic resistance status depending on the primers used, which is key in the growing era of antibiotic resistance and can help with tailored treatment for the patient. And this is how the Chow et al. Microfluidic system works, from the loading a bacterial sample with the H. pylori specific probes through to heating for thermolysis and DNA denaturation, and then hybridizing the DNA to specific probes in C. Then the magnetic beads are collected by the magnet contained within the system, and that transports the wash buffer to reaction chamber to wash out the debris and unbound material, and leading to the transport PCA mixture to the reaction chamber to perform the SMP PCR and detection of fluorescence by the PMT or photometric tube, all contained in one little chip. And then DNA aptamers. Wu et al. In 2021 have developed an aptamer-based sensor screening system that can detect H. pylori by use of a flashlight and the naked eye alone. As you can see here, it's very obvious the reaction. Aptamers are single-stranded functionalized nucleic acids selected by in vitro evolution of ligands by exponential enrichment screening, or SELECTS. This system would result in visible detection within 5 minutes by the H. pylori binding to the aptamer, which releases the fluorescent tag from the quencher. This is a competitive binding situation in which the HPA2, which is the HPA2, which is bound to the aptamer and the H. pylori system. So the fluorescence is directly proportional to the level of H. pylori in the sample. And a flashlight green over it means simple, clear results can be taken and can be easily incorporated to the system. Conclusions. H. pylori is one of the most common gram-negative pathogens responsible for a number of gastrointestinal disorders worldwide. Current test strategies include invasive testing to patients, which require specialized equipment and present risks to the patient and are restricted in the current pandemic, and non-invasive tests, which comprise a variety of RDTs and outpatient-type testing. Near-patient testing demonstrates apathic care for patients that limits the need for hospital stays and can be conducted remotely, but studies have demonstrated inconsistent results for current strategies. Microfluidics and DNA aptamers represent the future point of care or MPT strategies for patients for both diagnosis of H. pylori as well as monitoring of post-eradication therapy and the evaluation of antibiotic status. Here are my references, and thank you.